Hello everyone. Welcome to week 2 of the sports knee injuries rehabilitation course. Week 1 was taken by Professor and HOD, Department of Sports Medicine, AFMC, Colonel Rishikesh Pandey sir, and he spoke about the anatomy, the biomechanics, and the principles of acute injury of the knee. In week 2, we take this a step ahead. We will discuss the prehabilitation, the surgical decision making, and the planning for rehabilitation in cases of knee injuries of the athlete. The objectives of this lecture are to understand the principles of shared decision making between the doctor and the patient, to differentiate between the surgical and conservative management approach, to recognize the clinical, the functional, and the lifestyle factors which influence this decision making, to effectively communicate with the patients all the possible pros and cons of each decision, and to appreciate the importance of a multidisciplinary approach. To begin with, we start off with the introduction. This brings to mind a very important quote by a very important personality. His name is Dr. Peter Bruckner. He is a sports medicine specialist from Australia and author of a very widely popular book on clinical sports medicine. Dr. Peter Bruckner says, in sports, the coach and the athlete are at the center of a wheel, while all the other supporting personnels like the sports medicine specialist, the orthopedic surgeon, the physiotherapist, the psychologist, the sports nutritionist, the podiatrist, the sports masseur, the strength and conditioning specialist are all cogs of the wheel. What he tries to say is, in a hospital, the approach is very different. The doctor in the hospital decides the treatment and he conveys to the patient that this is the line of treatment with which we will go ahead with. If the patient agrees to that treatment, the doctor and his team proceeds with the treatment. But if the patient disagrees, the patient then either changes the hospital or he or she changes the doctor. But in sports medicine, the approach is a little different. Here, the coach and the athlete or the individual, they together decide what the approach would be the best approach for them moving ahead. In sports medicine, the approach is a little different. The coach and the athlete, they mutually decide what would be the best approach for them, because it is a matter of participation and non-participation. So here the decision is taken up by the athlete and his coach or her coach, while the supporting personnel can only give the options for them and let them choose which is best fit for them and which would best help the individual or the team or the country for which they play. So everyone else in a supporting role, while the athlete and the coach are the main players in this system. So when we say that the doctor and patient decide together, it's the doctor proposes the ideas and the management protocols, and the patient decides that which would be the best suited course for him or her. Whether the management would be a surgical intervention or would it be a non-surgical or a conservative intervention. The doctor provides the athlete or individual with all the possible choices and these choices then help the patient decide for himself. When the patient decides a treatment plan for himself, literature and research shows that the compliance of these patients is much better, and hence the prognosis and the overall treatment plan which is devised for these patients, it proceeds in a very good. The doctor provides the patients with a lot of options and treatment protocols, and the patient then decides which choices that he would or she would like to go ahead with. In literature and research, it is seen that when a patient decides for himself or herself, the compliance of the patient is much better, and the long term benefit attained by this process is greater than when the doctor decides the treatment and the patient has no say in it. So, um, it has to be a mutually agreeable decision, something that both the doctor and the patient are in agreement with. Coming to discuss the principles of shared decision making. in in this case, in this principle, the first principle is the doctor always needs to provide all treatment options to the patient clearly. Even if suppose a doctor is not very confident with a particular line of treatment, like for example, if there's a surgeon who only does open ACL reconstruction and does not do a arthroscopic repair, the doctor should always convey to the patient that a arthroscopic repair in his or her case would be more beneficial. This would then allow the patient to take a decision for himself or herself. A doctor needs to explain all the benefits and risk involved in the treatment, like the pros and cons of both the conservative management as well as the surgical management. Like the pro of surgical management is the pro of surgical management is it would provide a near complete rehabilitation in a high demand sport for an athlete, but there is chances of graft failure, there is chances of infection in the knee post surgery. So that is a con of surgery. In conservative management, uh, the approach would be non-surgical, but there are chances that even after 6 to 7 months of conservative management, the athlete may still feel instability and locking if it's present. So this so all the pros and cons of each treatment should be laid down and explained to the athlete. Now, athletes' physical demands are to be considered. Whether the athlete or individual wants to lead a routine life or wants some kind of sports participation, or wants to play at a professional level, wants to play at a recreational level, and what is the functional status of athlete? Is he sedentary? Is he uh, very active? Is he moderately active? Is he a weekend warrior, etc.? All these considerations will influence the decision of the approach which is selected. The best decision is the one which is mutually made by the patient and the doctor, because the doctor brings in the expertise in injury management, while the patient brings in the goals, the objectives, and the kind of functional life the patient desires, uh, and which and then helps to design the rehab protocol for the patient. Now let us discuss about the role and scope of conservative management. Conservative management in 70 to 80% of the time the first line of treatment which is resorted to. Irrespective of the injury, I I mean, if it's not an obvious and frank injury, patients and even sports medicine specialists and doctors, they prefer a conservative line of management. In the conservative line of management, the rehabilitation is done to build the strength of the individual, to improve the balance and coordination, and to improve the movement control. In conservative management, the doctors and the team of doctors, the sports medicine specialists, the orthopedic specialists, the physiotherapists, they focus on improving the strength of the individual and also to improve the balance and coordination. Pertinent to mention is the improvement of the neuromuscular coordination helps to improve the control of the movement of the individual over the muscles of the lower limb, which then helps to rehabilitate the patient better. The conservative management involves activity modification. If suppose a individual or athlete is into a very high dynamic sport, there has to be some activity modification, because one of the aim of conservative management is to limit the injury to the level that it is and not allow it to increase any further. This can be done with the help of either bracing or taping the injured limb. This can be done with This can be done with either bracing or taping the injured knee to limit the injury, and also by resorting to the police protocol, by providing medications for pain relief to the patient, and some physiotherapy modalities and exercises to improve. This can be done by introducing the police protocol. As you know that the police stands for prevention, optimum loading, icing, compression, elevation, and by introducing some medication, maybe for the pain that the individual is experiencing or the patient is experiencing, and the physiotherapy modalities, if they may be available, to improve the initial symptoms, to decrease the pain, to decrease the swelling, etc. Now let's talk about the surgical management. When is it indicated? A surgical management is indicated when the rehabilitation is undertaken for the period of 3 to 5 months, and still the patient does not show improvement proportion to the time spent in the rehab, or a rehabilitation program which has been carried out for 6 to 7 months, and the patient still feels that he is not confident about being able to perform at the highest level. He still complains of pain, he still complains of instability, locking, etc. Surgical management is also indicated for high demand sports. High demand sports which uh, needs a lot of pivoting movement in sports like basketball, football, hockey, cricket, etc. Further injury if not rehabilitated properly, for gross structural injuries and for multiple injuries. Suppose if there is a only a isolated partial ACL tear, then we can go for the conservative management. But suppose if there's ACL tear along with meniscus injury, along with an MCL injury, which is usually seen in a high velocity trauma incident, in such cases, we will need to progress to a surgical management, and that will be best suited for the individual. If the individual, even after rehab or even before rehab, complains of instability and locking. Instability is the feeling of giving weight. When a patient walks on a uneven surface, and if he or she feels that the a knee is not supporting his her movement, and the individual may dislocate the knee again, to say in layman terms. That feeling is called instability, and locking is usually associated with a bucket handle meniscus tear. Now let's discuss what are the factors that influence this decision making of whether an individual should go with the conservative management or with the surgical management. It's the age. First factor is the age of the individual. If the individual is a young individual, say 19 to 23 years old, and wishes to engage in a regular high velocity or high demand sport like basketball, football, volleyball, etc., then um, as a doctor, I would recommend a surgical management which will be best suited for an athlete of this age. But if an individual is suppose 50 years old and has broken his ACL in a recreational activity that he undertook over the weekend, and his point two is activity level. So, if an individual is an elite athlete or a professional athlete and engages in high demand sports and pivoting sports, then probably a surgical management would be better suited. But for an individual who has a very sedentary life or occasionally active, and who prefers to run and who prefers to run, a surgical management may not be the best option or choice for that individual. Third is associated injuries. If an individual has sustained an ACL injury along with a meniscus injury or along with an MCL injury, in cases where a patient has sustained a partial injury, a partial ACL tear or a partial MCL tear, then in such cases, a conservative management can be chosen depending on the sport of the individual. Fourthly, is the patient goals. What does the patient, or how does the patient want to lead a life after the rehabilitation? If the patient wishes to lead a very active life, then probably surgical management would be better suited. But if a patient is more keen on a sedentary life or a partially active life which involves only running, then conservative management can also be considered. Another important step is the counseling process of the patient. Here, we proceed with the SMART framework, where SMART stands for S stands for specific, and the time in which these goals are to be achieved. Also, these goals they have to be specific. They have to be objective goals so that they are measurable. They have to be attainable and realistic goals. As professionals, our job is to break down the complex jargons of the medical field into simple words and explain to an individual in a language that they understand best. So instead of saying an arthroscopic reconstruction of the right knee with a hamstring graft, we can say that a new graft will be placed while using a structure from your own hamstring to repair the structure which has been torn. Third is to correct misconceptions. Now, there are certain misconceptions in athletes that if they undergo surgery, they will be rehabilitated quickly and they can get back to sports as early as possible. Now, we all know that ACL rehab, irrespective of whether it's a conservative or a surgical approach, a conservative may take somewhere around 5 to 6 months, but may be longer for some athletes depending on the type of injury, while a surgical is definitely around 9 months, if not more. So, we need to explain these to the patient when they are deciding about which approach should they go ahead with. And the information that we give them should be in the form of visuals, diagrams, or charts, or maybe GIF images or videos from the internet, so that they can see for themselves and understand their own conditions. Now, to explain what I have elaborated before in this lecture itself, I have devised two case scenarios. The first case scenario is that of a recreational athlete. It's about a patient who is a 35-year-old and who plays football on weekends. In this patient, a conservative management or the physiotherapy. First case scenario is that of a recreational athlete. In this case, the patient is a 35-year-old who plays football on weekends. He's a recreational athlete and has sustained an ACL tear. Now, in this case, a conservative approach of physiotherapy, bracing, activity modification may be enough for the individual to lead a daily life. Of course, a surgical path or a surgical approach can be suggested for this athlete if he or she wants to go back to playing football over the weekends. But of course, a surgical management or surgical approach can be suggested for this patient who probably wants to go back to playing football over the weekends. But we need to decide this on what cost exactly. Because this decision of whether to go with a conservative or the surgical approach has impact on the patient's job, his role in the family, if he's the sole bread earner in the family, because 7 to 9 months of rehab will limit the individual's activities of going to the office. If the patient has a work from home kind of a setup, then probably this will be helpful for the individual. But what kind of sports does he or she wants to be involved with, and how much is the recovery time available, or how long can they be can and how much is the recovery time available, how long can they give the physiotherapy team or the rehab team to bringing them back to at least the functional level. Now, the second case is that of an elite athlete who is a 22-year-old professional basketball player and has sustained an ACL injury. In such cases, surgery is often recommended because the patient is young. He has sustained an injury to structure which is more frequently used in his sport. A lot of pivoting action takes place in basketball. A lot of jumping and landing actions takes place in basketball. It is a very high velocity, and it also involves the individual to move in very different planes. Unlike running is a activity which is in a single plane, more or less in a single plane, like in sagittal plane. But in activities like basketball or football, volleyball, etc., you are moving in different planes, not just sagittal, not just coronal, not just transverse also. Yeah, in fact, there are so many planes that you cannot even name them. So the movement is in different planes. So in such cases, a surgery would be a better recommendation for such an athlete. The prehabilitation of this athlete would involve strengthening of the muscles to improve the range of motion of the knee and to control the pain and swelling that the individual has sustained. Counseling of this patient will involve explaining the timeline of his or her return to play, the risk of re-injuries for this athlete, and the long rehab that the individual will have to undergo, the amount of patience that would be required from his side during the rehabilitation, and the compliance which would be required, because since it's such a long rehab protocol, we do not want to underdo it or overdo it as well. Overdoing it will cause probably more injury. Underdoing it will increase the time of rehabilitation and return to sport in such an individual. Now, in sports medicine, the role is a very umbrella kind of approach. Um, Under the umbrella is the orthopedic surgeon, the sports medicine specialist, the physiotherapist. There are so many support personals depending on the type and the level at which an individual plays. The orthopedic surgeon, in such cases, in cases of knee injuries, performs the surgical procedure and explains the process to the individual or the athlete. The sports medicine physician here oversees the entire rehabilitation, because it involves integration of not just the physiology and the rehab, it involves integration of the nutrition, the psychology of the individual, the biomechanics, so that the individual does not learn a wrong movement pattern. The physiotherapist oversees the primary rehab and tracks the progress of how the individual is recovering based on different criteria and even time bound measurements, objective measurements, and the strength and conditioning coach who works with um, the individual in the later half of the rehab, where the individual is supposed to transition from the rehab which was undertaken for him and while making a return to sport. Now, let's talk about the evidence present in terms of the surgical and conservative approach. Um, the data or the literature on this has to be shared with the individual based on the sport that they are involved in, be it basketball, volleyball, football, cricket, be it shot put, javelin throw, whatever the sport of the individual may be. Um, Even with surgical or conservative management, there is 80% chance that the individual may return to his original level, but there is a good 20% chance where the individual may not return to the original level at which he or she used to perform at. So this has to be disclosed to the patient so that an informed decision can be taken by the patient. We need to explain the re-tear risk, the arthritis progression, that is pretty common after ACL reconstruction is done in patients, because it is seen that post ACL reconstruction in long term, there are good chances that an individual may develop osteoarthritis due to the biomechanics which has altered after the surgery. There is no one size fits all theory that we follow. Even though in this course as well, we will be talking about the general criteria and the general laid down rules for rehabilitation. Uh, a physiotherapist or a sports medicine therapist has to be knowledgeable enough to integrate the biomechanics of the sport that the individual or his or her patient is involved with into the rehabilitation protocol that has been put forth by us in this course. The outcome of the same rehab protocol for two individuals having the same injury of the same sport may also vary. So we need to be very careful about this. We, even though there's a general guideline which is given, um, an individualized or a curtailed or a doctorized um, treatment protocol has to be made and put forth for individuals of different sport, or maybe even the same sport but maybe playing at different positions. There has to be a balance between the scientific data with the personal values of the patient, what the patient expects after the rehabilitation is done, whether the patient is going for a surgical management or conservative management. What are the expectations of the patient in this case has to be considered while we provide evidence about the scientific data about each approach. So we come to the end of lecture 6, and there are certain summaries and key takeaways from this lecture that I would like to discuss before we close this topic. First is that the shared decision making is a partnership between the patient and the doctor. The conservative care works well for many, but it works better especially for non-athletes because they don't have to go back to a high demand sport or perform at a very high level. But for the athletes of participating in a high demand sport or at the highest level, a surgical intervention is better suited if their injury demands so. Education and counseling are key to long-term success post rehabilitation, either by conservative or by surgical management. These are few of my references that I've used for this lecture. I'll see you in the next lecture. Thank you.